Hello, everybody. This is Dr. DeShavo. It is Chapter 10, Part 2, and we're moving out of the anatomy and physiology. Brief introduction, it is, but it is still there as an introduction for you. Now we're moving into dysfunctions and pathophysiologies of endocrine glands. This lists all that we're going to go through, and I think with endocrine, it is helpful to try to lump them together. So if you think of the pituitary gland, think of what can go wrong with it. And in general, it's going to be too much or too little of those substances or hormones that are released. So hypopituitarism or hyperpituitarism are two conditions that can happen with that pituitary gland. And then if you try to think of what can go wrong with the pancreas, that would lead to diabetes. If you think of disorders of the thyroid, you can have goiter, you can have myxedema, you can have hypothyroid, which is a hypothyroidism, hyperthyroidism, and causes of that. We're going to go through these steps. But, try to get a general working knowledge. And as you start studying these issues that can go wrong with endocrine, there's often multiple steps that can go wrong too, starting at the hypothalamus, pituitary, and the gland itself. And I think if you try to think of those three steps along with what can increase or decrease the functionality of that organ, is that even a word? Sounded good. Functionality, I'm not sure. But anyway, if you think about what can increase or decrease how that organ is functioning, it can really help you to understand these really crazy endocrine conditions. So this is a list of what they are, a general overview. Let's get right into the conditions themselves. So with pituitary dysfunctions, don't forget that if there is a dysfunction in the hypothalamus, it can lead to any of these dysfunctions in the pituitary. So, for example, my uncle, God rest his soul, had a hypothalamic tumor, and he had all sorts of issues with pituitary hormones. Growth hormone was decreased, so he was losing muscle mass. His thyroid gland was going up and down depending on what was happening in that hypothalamic tumor to begin with. So if you're getting multiple glandular dysfunctions, you always want to look to pituitary and hypothalamus. It could happen at either one of them. We're just going to focus on what can go wrong with the pituitary gland itself. I just want you to keep in mind that the hypothalamus can contribute to these issues in the pituitary. So hypopituitarism is going to be very rare, but this is where not sufficient amounts of hormones from the pituitary can manifest. So this can be congenital, could be some sort of trauma. Tumors should really be included in there as well. So this can lead, for two examples, to dwarfism, which would be a short stature in patients, and this would be because of a deficient level of growth hormone. Growth hormone allows bones and muscles to grow to their proper length and width. So this could lead to a short stature, obviously, if we don't have enough of this released. Diabetes insipidus can affect the posterior pituitary. Don't forget growth hormone is anterior. ADH is posterior. So this will lead to excessive fluid excretion in the kidneys caused by a deficient release of ADH. This is more seen with trauma, some sort of head trauma, which will affect that posterior pituitary and decrease the release of ADH. Hyperpituitarism is going to be obviously when we're going to release too much of the pituitary hormones. We can also have tumors that secrete this hormone or hormone-like substances. We looked at this with the increased release of ACTH with lung tumors, for example. This can lead to issues such as gigantism, acromegaly, and SIADH, which we spoke about previously in renal. Now, gigantism, the difference between this and acromegaly is that large levels or excessive amounts of growth hormone are released prior to puberty. And we'll go over this in skeletal system, but remember we have growth plates. And those growth plates close in females at about let's just say in males and females between 18 to 21. We'll break down what the specifics are when we get into bone. So anyway, growth plates will close in females and males between 18 and 21. So if somebody has an excessive release of growth hormone prior to puberty, they can grow very tall, leading to gigantism. Their bones also can grow thicker and bigger than somebody who doesn't have it. Acromegaly occurs when somebody releases growth hormone after those growth plates have closed. So this will increase the bone size width-wise, and also thickness-wise, causing their face to get much wider, their bones to get wider, their forehead to get thicker, as opposed to them being very tall. SIADH we studied about already, so I'm just going to briefly go through it. This is going to be an increase in water retention because we're releasing too much antidiuretic hormone. We can also have hyperprolactinemia, which is excessive prolactin release. So this can cause issues with menstrual dysfunction and also an increase in the production of milk in the breasts. And this could happen in male or female, which would cause an increase in the size of the breasts. Cushing's syndrome is going to be when excessive cortisol that's released from the adrenal glands. And with that excessive cortisol, we can have an increased release in serum glucose, and we spoke about that before, which can cause with the Cushing's syndrome, so once again, we can have that excessive cortisol, which will increase serum levels of glucose. It can lead to other signs and symptoms, which are known as moon faces, which is an excessively round face, and also something called a buffalo hump, which we're going to look at when we get further into some of these endocrinological syndromes. So hyperthyroidism is going to be an increase in our metabolic state. And those thyroid hormones, T3 and T4, can be the cause of it due to damage or a problem with the thyroid, which we're going to look at in a little bit. But we can also have an increase in TSH from the anterior pituitary, which would overly stimulate that thyroid gland, causing the same signs and symptoms as hyperthyroidism caused as damage or issues such as autoimmune issues with the thyroid itself. And we'll get into that when we get to the thyroid gland itself. So let's practice a little bit. What might these be? And these are pretty easy, but I just like to get you thinking. Now, you're going to know what this is on the left. What might this be caused by? Think about that. If you can't remember, go back and review the notes. And look at the right. What do you think that might be? Specifically, what might cause it? And once again, if you can't remember, go back to the notes. And as I said, those are pretty easy. Dwarfism and then gigantism on the right. And these are the examples in your book. Now, what might this be? Now, think about what we spoke about, where it comes from, and why it would present such as this. This is the same female from left to right. You can see her obviously by herself in the left as we're looking at it. In the middle picture, she's the only female. To the right, she is the tallest one there. What do you think this is an example of and why? Yep, this is going to be acromegaly. Now, I want you to think what these might be examples of, these pictures. Is this going to be acromegaly or gigantism, and why? And I asked you to think about how you can tell the difference, and you probably have guessed this is acromegaly. And acromegaly will present with someone who stays approximately the same height or stature, but their faces get wider and thicker as they get older. And I really think the best example is that bottom. You can see that's the same female progressing through acromegaly as she gets older. Her height doesn't change because her growth plates are already closed. So acromegaly will release that excessive growth hormone after the growth plates are closed, as opposed to gigantism, which happens before and they have a tall stature. Now, pancreas, to sugar or to not, big question. And obviously we will talk about diabetes mellitus in this chapter because this is endocrinological function, and we've definitely gone over the enzymes that are released for digestive functions previously. So with diabetes, this is bread and butter stuff, and these are conditions that you should know very, very well. And I actually have another video that reviews diabetes, which I will upload for you to connect to. And make sure you review this, understand the anatomy, the physiology, and the manifestations of these different forms, because many people have diabetes, unfortunately, and it could be from an autoimmune possible or viral issue, but a lot of diabetes we're seeing with obesity, unfortunately. And I have a couple of videos about that link, and also about how insulin gets into the cells. So in your supplemental media, make sure you review those videos. All right, so diabetes mellitus. So this is going to be an issue. So this is going to be an issue with hyperglycemia. So once again, to review, we ingest glucose. Glucose is absorbed into the intestinal tract, through the liver, and then into the bloodstream. We need to take that glucose and put it into cells through the actions of insulin. Insulin needs to be present in order for our cells to get glucose. Once glucose is inside of our cells, and pretty much all the cells of the body, or the cells that we're talking about, they will create energy for us, these little droplets of glucose, okay? Excuse me. If we don't use glucose immediately, insulin will also help to store glucose as glycogen in the liver and skeletal muscles. Okay, so that's the process. The last step of excess glucose is we store it as fat. Okay, so that's why excessive amount of sugar is not good for us, because if we don't use it, we turn it into fat. So with diabetes, there's an issue where people cannot get the sugar into their cells. So they either don't have enough insulin, or the insulin is inefficient at working at getting the glucose into the cells. You can also get to the point where both are an issue, and I'll walk you through how those steps happened. So impaired insulin production or action results in abnormal carb, protein, and fat metabolism because we can't get glucose into the cells. We can't use that as energy. We'll start using fat and then protein for energy. We also can't store enough glucose to be used in future periods of time if we are glucose deficient. Nearly 26 million Americans have diabetes. That's a staggering amount. 347 million people worldwide have diabetes, which is even more staggering. And it is just a huge contributor towards death and also healthcare costs. You guys see it all the time. People who have diabetes, what will happen because of the sugar, and this is something you should write down. I'm kind of going off-road in here, but so people with diabetes, what happens is the excessive amounts of glucose in the bloodstream will lead to two huge issues. They'll lead to inflammation, and I have a video in your supplemental media for this as well. So if we look at the lining of blood vessels on end, as opposed to them being a long tube, the glucose can actually draw inflammatory mediators to the lining of blood vessels, which can eventually harden those blood vessels and decrease the diameter of the blood vessels, which we know increases blood pressure already, But with really small capillaries of the body, it can completely block them, so they don't have fresh blood running through them. And we'll see this especially in the distal extremities, the feet and the hands first, and then it can move more proximally. And what happens is blood vessels, it really can happen anywhere. It doesn't necessarily just have to be extremities. That just tends to be where it manifests. It blocks the blood flow. You can't get fresh blood flow to the distal tissues. And what also happens, because you have the excess glucose that is in the bloodstream, bacteria and viruses can thrive on it, and we could get infections in the distal extremities with people with diabetes. So it's kind of a 1-2 punch where we damage those blood vessels, and we also can, because of the excessive glucose that's deposited in their bloodstream and their tissues, because it's not being used in cells, it's just hanging out in the bloodstream and the tissues, we can get bacteria and viruses that really love to thrive on that in those distal extremities, and they get necrosis into their tissues. You also, because of the damage to blood vessels, get more atherosclerosis, more high blood pressure, blocked blood vessels in the heart. It's just a devastating disease, really. And here's a list of those complications. And once again, I won't list these, but if you understand the mechanisms of diabetes, you should be able to understand how these affect. So hyperglycemia, you know about. Diabetic ketoacidosis, you know about as well. Hypoglycemia, if you have an upsurge in your injections of insulin and you do too much and you don't have enough glucose to join in with that insulin, you'll go into hypoglycemia. Heart disease, stroke, hypertension, diabetic retinopathy, which is damaged retina, blindness, kidney disease, all of those are going to be, it continues on the other side. All of those are because of that damage and inflammation that diabetes causes inside of the blood vessels that we spoke about. It doesn't allow blood to get out to the tissues and nourish those tissues and create healthy tissues. So you know all of these manifestations. I'm sure you know what hyperglycemia means. Glucoseuria, you know what that means, and glucose in the urine. Increased urination, polyuria, increased eating, polydipsia, because even though they have a lot of glucose in their bloodstream, their tissues are starving. That's increased water intake. Polyphagia is increased food intake. But both will be true because with polyphagia, your body thinks it's starving. It wants you to bring in more food because even though it has high levels of serum glucose, it's not being used in the cells. So you become very hungry. Polydipsia, or increased fluid, is because your body is trying to balance out those high serum levels of glucose and is trying to make it more of an isotonic solution. So you get very thirsty, and you're also urinating a lot because there's a lot of glucose getting dumped into your urine. So you're dumping water with it to try to once again create a balance of those tonicity of those solutions. So blurred vision, fatigue are all signs and symptoms as well, because you're not having that proper usage of the glucose and you're exhausted because you're not creating energy, and weight loss because you're also not using that glucose to get into the cells to be used. You're just dumping it. You're dumping a lot of fluid and you're creating a lot of weight loss that way as well. So many issues from diabetes. So type 1, it was previously called insulin dependent and juvenile onset. We only call it type 1 now because type 2 we're seeing is becoming insulin dependent as well. Because it's progressing so far into the disease. This happens when there is some sort of autoimmune destruction of the pancreatic beta cells, which release insulin. Okay, they have to inject insulin or they have the pump. There's been some research in trying to redevelop those islets of Langerhans, but it hasn't been really super successful yet. I think there's been some success, but that would be pretty cool if they could reestablish their islets of Langerhans again. Usually happens in younger adults. It can absolutely happen at any age. I know somebody who ended up getting this type 1 after gestational diabetes for some reason. Oddly enough, it progressed in her. I'm guessing she sort of had some latent issues that may have led to it anyway, and it really was stimulated when she had her child. So it could also be, there's some theories that it's viral or some environmental trigger, and genetically susceptible people may as well. I know somebody I went to high school with who used to literally have sugar at every meal, and she ended up being type 1. And I really wonder if that extreme stress on the pancreas eventually, and this is totally opinion off the books, but I found it pretty interesting that it hit pretty hard with her. And I wonder if maybe that constant stress on the islets of Langerhans maybe didn't perpetuate that disease or stimulate it to come on even sooner. Type 2 is going to be what was previously called non-insulin dependent, but this eventually can lead to insulin dependency. I think that's why they changed the names. And this quite often is an adult onset presentation. I'll be curious to see if it doesn't start to present in younger people because of the amounts of obesity in our population anymore. It's becoming a rampant disease. So this accounts for 95% of newly diagnosed adult cases. Usually begins as insulin resistance. So what that means is that they're still secreting insulin from the islets of Langerhans, but that insulin is not efficient at getting glucose into the cells. And the increased levels of fat in our system makes this happen and contributes to this insulin resistance, or the inability of insulin to act as an efficient mediator to get glucose into cells. If it continues and they do not lose weight and start taking care of their bodies, it can lead to decreased levels of insulin being released from those beta cells in the islets of Langerhans. So advancing age, obesity, and then they usually can treat it with oral antidiabetic. Sorry, I keep sneezing this morning. I don't know if you could tell I'm pausing the tape. So I meant to say anti-diabetic, but I was about to sneeze, so I was trying to hurry up through it. I said antibiotic. That's not what I meant. Anti-diabetic medications that are going to help them to process the glucose a little bit better. Okay. As it progresses, if it continues and they don't lose weight, supplemental insulin is quite often needed. Here's the diagnostic procedures and treatment. I thought you might like to have this. I won't test you from it, but you want to maintain your glucose levels, excuse me, and also blood pressure and cholesterol levels as well, to make sure that you're trying to decrease the stress on the pancreas and increase the functionality or the functioning of the insulin getting glucose into cells. Here's type 1 versus type 2, which we went over in those notes. But once again, if it gives you a good way to review it, I thought this chart would be helpful. Now, gestational diabetes is going to be during pregnancy, and I'm sure this sounds familiar to you. So people who put on a lot of weight with pregnancy, sometimes if they can be a little bit more careful with their weight, obviously you don't want to lose weight, but you want to try to maintain a good, healthy weight gain, they can help to decrease gestational diabetes and hopefully live without insulin. If it continues, they may have to add insulin into their regimen. This may continue if they're not careful after the pregnancy. You will have a 40 to 60% increase within 5 to 10 years, especially if you're not careful about your weight after you have your baby. Now, metabolic syndrome, we're seeing, oh my gosh, it is just so rampant in our society because of weight gain. And with the weight gain, obviously, you're going to have increase in glucose and triglyceride levels. As you can see there, hyperglycemia, hypercholesterolemia, which may lead to high blood pressure. And with weight gain, you're going to have an increased waist circumference. If you have 3 or more of those, by definition, you have metabolic syndrome. It's not a form of diabetes, but it can lead to diabetes, which can lead to all those other issues that we spoke about previously. They're saying diagnostic criteria is the presence of more than one of those risk factors. I've read more than 3. Okay, so I pulled these notes right out of your book. And some of these things, we just have differing opinions. So I said 3, that's what we'll go with if we're going through testing. Obviously, a huge way to treat this is going to be focusing on those lifestyle changes. All right, good old question time. Who needs injections of insulin? Type 1 diabetic, type 2 diabetic, gestational diabetic, or all of the above? What do you think? Go ahead and answer that, and I will see you in the next video.